Okay, so you've already heard earlier this morning from Dr. Menser regarding diagnosing PML and the consortium that developed and the elements of that, but it's worth going through again. So we have our standard PML diagnostic measures. So to begin with are the clinical manifestations, and because PML can affect virtually any area of the brain, there are a wide variety of clinical manifestations that can occur. However, there are certain things that we don't see with PML, such as optic neuritis and myelitis. And when you're treating a patient that has multiple sclerosis, when you see those things as clinical manifestations, you could feel quite comfortable that indeed this is not the consequence of PML. Earlier today, we saw what the clinical manifestations were in the natalizumab-associated group. They're not terribly different in the AIDS-associated group. This comes from a series that I collected while I lived in South Florida of 154 patients with AIDS-related PML. And what you see is that patients will present commonly with weakness of one side of their body, gait disturbance, cognitive problems, behavioral problems, speech and language abnormalities, hemisensory deficits, visual field deficits, and even ocular palsy. So these are the types of manifestations that one might see as the seminal manifestations of PML. So you have clinical manifestations. The second thing that you need are MRI abnormalities. And these MRI abnormalities include such things as increased signal on T2 weighted image and FLAIR, often hypointense on T1 weighted image, generally no mass effect unless you have a superimposed iris. The lesions generally involve parieto-occipital and frontal lobes. They're the most common sites, at least they had been in the AIDS population and the pre-AIDS population. But we do see it in atypical locations like the cerebellum, the brainstem, even the basal ganglia. And when we went, you'd say, well, that doesn't make sense. Why would you see it in the basal ganglia? That's gray matter. Well, it turns out that there are a lot of medullated fibers that pass through the basal ganglia. And when we did a radiographic pathologic correlation, looking at what we saw radiographically with what we saw at autopsy, it was chiefly, not exclusively, these medullated fibers that were involved when we saw involvement of the basal ganglia. Even the temporal lobe was involved, and gadolinium enhancement. Now, in the era before the availability of highly active antiretroviral therapy, just under 10% of the patients in this series had CT scan enhancement with iodinated contrast, and just under 15% had gadolinium enhancement on MRI. And so I couldn't tell you whether this was the consequence of iris or not. We weren't treating them with anything, and we didn't biopsy that many of them. Okay, so let me show you some of the pictures. On the left is the CT scan. On the right is the MRI. This is a patient that came to autopsy. We knew that they had PML. This is an AIDS-related patient with PML. And again, you see multifocal lesions, but as has been well pointed out, this can be a unifocal disease. In fact, I think it was Dr. Korelnik that mentioned the fact that maybe progressive multifocal leukoencephalopathy isn't the appropriate term for this disease, since it needn't be progressive, it needn't be multifocal, and we know that JC virus needn't only involve the white matter. This is a patient that had been on natalizumab, and what you see is this contrast enhancement, this punctate peripheral contrast enhancement that we think is likely the consequence of inflammation. And I show you this to emphasize the point that what we see radiographically is very closely tied to what we see pathologically. Just to give you a little history about this patient, he was in his early teens when he came to see me. He was aphasic. He had a disease called congenital biliary atresia. He had 3 liver transplants. And at the time of one of the liver transplants, we presume he was infected with HIV, which wasn't diagnosed until he was 6 years old and came in with very severe psoriasis. And an astute pediatrician said, wait a minute, that can occur with HIV. We should check him for HIV, and he was HIV positive. And he came in with the aphasia as his terminal AIDS-related event and came to autopsy. And on the left, you see the MRI. On the right is that same brain, the same location, what we saw at autopsy. So there's a very tight correlation between what one sees pathologically and radiographically. So the third feature that you need are spinal fluid evidence of the virus. So here are the measures that we use as the standard PML diagnostic measures. Clinical manifestations compatible with PML, MRI features compatible with PML, and spinal fluid that shows JC virus. And you go, bingo, I've got it. Presuming that there's not something else that better explains what you're seeing. However, there are a few caveats with respect to spinal fluid, and I'm sure that after this talk, Gene Major's going to twist my arm and say, why did you use those terms, false negative and false positive? I happen to like them, but he doesn't. He likes using the terms undetectable or detectable. In any event, if one uses routine PCR as opposed to an ultrasensitive PCR, the published data suggests that as many as 25% of individuals with what ultimately turns out to be PML have falsely negative or undetectable virus. And even with ultrasensitive PCR, perhaps the number is as high as 5%. Of course, it varies from laboratory to laboratory. The point that I want to leave you with is that it is sometimes extraordinarily difficult to find the virus in the spinal fluid, and you're stuck with somebody who has the clinical manifestations, the MRI manifestations, and you're scratching your head and saying, but the spinal fluid's been persistently negative. What do I do next? I'll tell you what you do next in a second, by the way. The other thing that I want to leave you with is to bring to your attention what I found to be a fascinating paper by a group of Swedish investigators working in collaboration with Dr. Major's laboratory. And what they found was that a small number of individuals that had multiple sclerosis with no evidence of PML whatsoever had JC virus in their spinal fluid when you looked with an ultrasensitive technique. It was 2 of 217 patients, just under 1%. It was 1 of 210 people, or 0.5%, who had, in which the spinal fluid was cell-free, and the copy numbers were low. It was 103 copy numbers per ml. And it was 1 of 42 in which there were CSF cell samples. And again, the copy numbers were low, on 25 copies per ml. But the point to be made, and this shouldn't surprise us, that from time to time, we're going to find this virus as we found other virus in people who are otherwise pristine, just percolating through their spinal fluids. Many years ago, I did a study where we did lumbar punctures on people with HIV, with and without neurologic disease. And this was in an era before PCR. And what we did was we cultured for these viruses. And what we found is a small number of perfectly healthy HIV-infected individuals had adenovirus and enterovirus and even herpes viruses that you can culture out of their spinal fluid. So this doesn't surprise me, but it does make it a little more difficult when you want to use the spinal fluid as one of those absolute parameters. The other thing I mentioned earlier this morning, and that is in individuals that have had iris, where you think that the virus should be gone, it turns out that isn't the case, and this also comes from the Major laboratory. 13 of 35 patients with natalizumab-associated PML after iris had JC virus detectable in their spinal fluid, and some it was up to 5 months later. So then if that's the case, what are we going to use as our gold standard? And we don't resort to this terribly often. I will tell you that there's been a general reluctance by many neurosurgeons to biopsy patients who we suspect of having PML, and that was particularly true in the HIV setting. In fact, many of the surgeons wouldn't want to touch them with a 10-foot pole. I recall when I was at the University of Miami where there was an abundance of patients where we were diagnostically perplexed. I had to promise a neurosurgeon that he would be on every publication if he would do the biopsies. That was the only way I'd get a neurosurgeon to biopsy him. They just simply didn't want to do that. It's much better at the University of Kentucky. In any event, biopsy and autopsy are really gold standards, but we don't want to wait for the autopsy, do we? And there you want to see the characteristic histopathologic triad of demyelination, bizarre astrocytes, and enlarged oligodendroglial nuclei. And you want to demonstrate that the virus is there by electron microscopy or immunohistochemistry. And I showed you this picture earlier. On the left side is what we see. Here's a moth-eaten appearance subcortically, a demyelinated brain of one of my patients. And this is the H&E Luxol fast blue stain on the right. That area that's white should all be blue, but it's white because the myelin has been lost. And if one looks histopathologically, you see these puff balls of demyelination in that left quadrant of the picture, left upper quadrant, that occur perivascularly. Generally, there's axonal preservation, as you see right below it, and you'll see bizarre astrocytes. And that is, by the way, one of the reasons why one of the seminal cases was misdiagnosed, because they misdiagnosed that patient as a glioma, and they saw these bizarre astrocytes and thought, oh, this must be a malignancy. They can look very malignant in nature. And in the bottom slide, the enlarged oligodendroglial nuclei. And then you'd like to demonstrate that indeed there is the virus present. And you can do that by electron microscopy or immunohistochemistry, as is demonstrated on this slide. Now, I'm going to change hats a little bit and put on my MS hat as opposed to my PML hat. As an MS doctor, there's an entity that we call radiographically isolated MS. This is where a patient comes in to see you, and they've had headaches. And the doctor said, you know what, I need to get an MRI on you. You have headaches. And they do an MRI, and lo and behold, they're chock full of lesions that look just like MS. And you go, well, you know, maybe it's something else. Maybe it's small vessel disease. But you do a lumbar puncture on them, and the lumbar puncture comes back with elevated IgG and oligoclonal bands, yet the patient's not had anything. They say, well, I don't remember having anything that smacks of multiple sclerosis. This is a well-described entity. It's called radiographically isolated multiple sclerosis. Guess what? We have this same thing with PML, and it was alluded to by Carmen earlier this morning, that small number of individuals that have been demonstrated to have PML, but it was found on an MRI before they developed any clinical symptoms. And I'm just going to show you a couple of these cases. This was one of the seminal cases reported in the New England Journal. It was reported by Annetta Langer Gould and colleagues, 23-year-old man with MS on natalizumab for 24 months. At 24 months, he showed a new lesion. So on the left side, you see that there's nothing here in the right frontal lobe, but a year later, when they do a routine follow-up MRI, they see this lesion here. And initially, they assumed that this was due to multiple sclerosis. At that time, they didn't describe any clinical abnormalities. It wasn't until a month later that he was noticed to be behaving strangely. So this would have been regarded as radiographically isolated MS. And another patient whose scans you saw earlier, by the way, I think Professor Gold showed them, was the Linda case. So this was also published in the New England Journal. Here's a 35-year-old man. He started on natalizumab in January of 2007. In January of 2008, so this picture right here, they didn't notice it until they went back and looked at it retrospectively. There's this little white matter lesion that's developing. The MRI read was there are no new lesions. 4 months later, he develops myoclonic jerking of the left arm. And it wasn't until July of 2008 that they start seeing the lesion for what it is. And it was very difficult to diagnose this patient because repeated spinal fluids were negative in this individual. So that's another illustrative case. So there's another diagnosis that we need to make, and that is radiographically isolated PML. Since the plan is to imaged patients on these monoclonal antibody therapies that increase one's risk of PML at set intervals, be it 6 months or 1 year or whatever, you are going to see these lesions arise prior to the onset of any symptoms. Therefore, you must have a high index of suspicion of PML, and it must be entertained even in the absence of any clinical manifestations. And we must expand our diagnostic criteria to permit diagnosis of PML based on radiographic and laboratory criteria alone. Now, I just want to show you a case that will tell you how difficult it may be to make the diagnosis of PML or to feel comfortable that what you have is not PML. And this was a patient that I was involved, in whose care I was involved with several years ago, and we actually reported this patient. He's a 27-year-old man. He's had MS symptoms since his teens, but his diagnosis wasn't made until 2006. He had not responded to the standard platform therapy, so he was started on natalizumab in April of 2008, and his MRI from April of 2008 are these top 2 panels. With every infusion of Tysabri, he had an allergic reaction, and the doctor who was caring for him after the 4th infusion said, I don't think I'm going to continue it any longer. In August of 2008, 1 month after his 4th infusion, he developed confusion and behavioral changes. This, by the way, these are not typical findings clinically of individuals with multiple sclerosis, confusion and behavioral changes. He also developed worsening hemianesthesia and increased dysarthria. He had a lumbar puncture that showed 14 to 28 cells, an elevated protein, an elevated IgG index, an elevated myelin basic protein, and his JC virus PCR was negative on 2 occasions. He, by the way, had been given 1 course of intravenous methylprednisolone because when he first presented to the emergency room, before the physician had a chance to see the MRI, he said, just go ahead and, I think it's just an MS relapse, just give him a course of IV methylprednisolone. So he got 1 course of IV methylprednisolone, and then the doctor went down, looked at the MRI, which we see in this second set in the middle panels, and he goes, oh my God, I'll bet you he has PML. And of course, then we got these negative JC virus in the spinal fluid, and we're saying, well, maybe it's not PML. Maybe this is just MS. Now, mind you, this is only a month after the natalizumab had been discontinued. I shared this case with a group called the Neuroinfectious Disease Group, which is a group of neurologists, Dave's a member of it, who have an interest in neuroinfectious diseases. It's a subgroup of the American Academy of Neurology. So I passed it around, and I said, tell me what you think this is. Do you think it's a giant MS plaque, or do you think this is PML that's aborted? And there was not uniformity. I will tell you that a distinct minority, some very well-known people, felt this was aborted PML with a negative JC virus study in the spinal fluid. In any event, I've seen him subsequently. 3 years out, he's doing reasonably well. He had significant recovery from his problems. And I guess it's a moot question then, whether it was PML or a giant MS plaque. So I'll leave you with this by Jean-Martin Charcot, who said, to learn how to treat disease, one must learn how to recognize it. The diagnosis is the best trump in the scheme of treatment. And I'm sure he said it in French. Thank you very much.